faculties and dear students. At PGCR, we try to cover the topics which are of interest to all the faculties and very important. So we search for those topics, and X-ray reading is one of them, which is very important, a very basic test, and we all should master the art of. The moderator is Dr. Chowdhary, and chairperson for today's sessions are Dr. Paresh and Dr. Sunil. Over to you, Dr. Chandra.
A very good morning to respected Emeritus Chairperson Sir, Vice Chancellor Sir, VP Sir, NS Sir, esteemed faculty members and dear students. Today we embark on an essential journey through the intricacies of interpreting a chest radiograph, which is a fundamental skill in the field of medicine. A chest radiograph is the most commonly requested investigation in radiology. Of entire workload in X-ray department, about 50% of X-rays are chest radiographs. Chest radiographs provide critical insights into the thoracic cavity, revealing information about lungs, heart, major vessels, bones, soft tissues, lower neck and upper abdomen. They are often the first imaging modality employed in the evaluation of thoracic conditions. So it is extremely important to know how to interpret a chest radiograph, not only for the radiologist, but for people of all the branches in the field of medicine. We have divided our presentation on chest radiography in two parts. Today in part 1, we will understand the process of acquiring a chest radiograph. We will see how to assess the quality of a chest radiograph, which is very important. We will discuss the various views done and their common indications. We will study the normal anatomy on a chest radiograph. And lastly, we will discuss what all we can see and we should see in a chest radiograph. Part 2 of our presentation will be covered in next PGCR, in which we will discuss the approach to read a chest radiograph. We will study the various patterns of pathology, and we will discuss common clinical scenarios on a chest radiograph in collaboration with departments of medicine and respiratory medicine. So as we progress in this presentation, I request you to engage actively, ask questions and share your own experiences and challenges in radiographic interpretation. By the end of today's session, our goal is for everyone to know how a normal chest radiograph looks like. So let's get started on this enlightening journey into the world of chest radiography. I would like to call upon Dr. Sarthak to start the presentation.
Thank you, sir. Good morning, respected dignitaries, faculty, and my dear students, seniors and colleagues. Today, I will be speaking on the process of acquiring a chest radiograph, assessing its quality, and the various views and their indications. So, acquiring a chest radiograph, we start with patient registration. This involves taking patient details like patient's full name, age, gender, and UNAR number. This is a non-invasive investigation with no use of contrast, therefore we have implied consent. After that, we look at the requisition form and take a clinical history. If the patient is a female of reproductive age group, we ask for the date of her last menstrual period, that is the LMP, and follow the 10-day rule. What is that? The rule states that non-urgent radiological examinations that expose a female of reproductive age group to ionizing radiation should ideally be scheduled within the first 10 days of the menstrual cycle, i.e. within the first 10 days of the onset of menstruation. Now, a word about radiation safety. Radiation exposure in diagnostic radiology.
Sorry, this is very important because in the second half of a cycle where the female has had a period, pregnancy may still be there. So I want to know from clinical residents as well as radiology residents, are we strictly following this rule?
This is very important and we have to follow it. We have to be very strict.
Now, a word about radiation safety. So radiation exposure in diagnostic radiology is measured in millisievert or MSV, which is a measure of the potential biological impact of exposure to ionizing radiation. For radiation workers, the upper limit of exposure is 20 millisieverts per year, which is averaged over 5 years, with no single year exceeding 50 millisieverts. And for general public, we consider a limit of 1 millisievert per year. So the effective radiation dose on a standard PA chest radiograph is 0.1 to 0.2 millisievert. However, so in pregnant females, for the entire duration of pregnancy, ideally we avoid all non-emergent radiological investigations with ionizing radiation in pregnant women, regardless of period of gestation. However, if there is exposure, until 50 millisieverts throughout the entire duration of a pregnancy, there are no proven potential effects on the embryo or fetus at any dose and at any period of gestation. Between 50 to 100 millisieverts at less than 2 weeks period of gestation or more than 18 weeks period of gestation, there are no proven potential effects. And between 3 to 17 weeks of period of gestation, there are potential effects that are uncertain and are too subtle to be detected. Above 100 millisieverts, however, at less than 2 weeks period of gestation and more than 27 weeks of period of gestation, there are no proven potential effects. Between 3 to 4 weeks, there are chances of possible spontaneous abortion. Between 5 to 10 weeks, there are possibilities of malformations. And between 10 and 27 weeks, there are intelligence quotient deficits and neurological defects as well.
Effective radiation dose of a standard chest PA is 0.1 to 0.2 MSV.
Yes, sir.
And up to 50 there is no side effect.
Yes, sir.
Then why are we so strict with this?
So because these studies are about the deterministic effects of radiation, the stochastic or the non-deterministic effects which are based on chance, such as genetic problems or maybe cancer development, these are non-dose dependent. So in a fetus, they become exponentially more important to take care of.
And the patient may require further investigation during the gestation. So that's why we have to be as safe as possible.
For our benefit, can you enumerate which radiological investigations would give exposure up to 50 or 100?
So this is for the duration of the entire pregnancy. Beyond that, in a standard in a standard head CT, we have about 1 to 2 millisieverts of radiation, and for a HR CT or a thorax CT, it goes about 7 to 8, and for an abdominal CT, it can range from 12 to 30.
Cumulative radiation dose, cumulative, as many as X-ray, CT, whatever is done, all are added up and gives cumulative.
What is the X-ray exposure during the intercontinental flights? Is it more than normal chest X-ray? Anybody can answer that?
Now, chest radiography, as stated by Jay sir, is one of the most common first-line investigations for a number of conditions like cough, dyspnea, hemoptysis, cardiomegaly, perforation, and in preoperative PGCR evaluation as well.
For surgical residents, this is very important. If you are suspecting a hollow viscous perforation, the investigation of choice is a chest X-ray including the domes of diaphragm in a sitting or standing position and not an abdominal X-ray.
X-ray is essential when you go after shaping of the abdomen.
So for a pregnant female, if an X-ray is essential, we do lead shielding of the abdomen if chest X-ray is required. However, that does not provide, it provides some protection, but it does not negate the stochastic impact risk.
Still in practice.
Yes, sir.
Yeah, patient is pregnant and generally we do it into the second and third trimester. First trimester generally our aim is to avoid any type of the radiation. The reason being the part is formation of all the organ is into the first trimester. And that second and third trimester is good. The first trimester when there is a formation of the part is always
There are different technologies used for acquiring radiographs. Namely, in today's day and age, we get them primarily by two technologies. First is computer radiography or CR, and the second is direct radiography or DR. So the main difference between CR and DR is the method of image capture. So in CR we use cassettes. Now cassettes need to be taken to a reader to digitize the image. The speed is slower because of manual cassette handling and reading, and the image quality is slightly lower. In DR, we use flat panel direct detectors. There are no cassettes involved. The image appears instantly on a workstation. There is no separate reader. It is faster and fully digitally integrated and generally superior when it comes to image quality. Our department is equipped with both standalone as well as portable state-of-the-art digital radiography machines. So now we move on to evaluating a chest radiograph for technical adequacy or quality. There are 5 important factors for an adequate chest radiograph. These are penetration, rotation, inspiration, magnification, and angulation. Excuse me. Now, coming to penetration, this refers to the degree to which the X-ray beam passes through the patient's body and reaches the detector. The penetration or exposure is determined by the voltage settings, that is the kilovoltage peak or kVp on the X-ray tube. A chest radiograph is typically done at a kVp of 50 to 60 in A chest radiograph is typically done at a kVp of 50 to 60 in both CR and DR systems. So, in a well-penetrated and a well-exposed chest radiograph, the vertebral bodies are just discernible through the heart on the frontal film. In an underexposed film, the film is too soft, the details get missed out. They can mimic or hide conditions like consolidation effusion. On overexposure, the lung fields are too dark or too lucid. The lung markings become faint. So this can mask pathologies like nodules and interstitial disease. Now we have inspiration, or rather depth of inspiration. The level of inspiration can be estimated by counting the number of ribs. Visualization of 6 anterior or 10 posterior ribs over the dome of the diaphragm indicates adequate inspiration. So the first image is an example of adequate inspiration. The second is an example of shallow inspiration. Now shallow inspiration will cause the lung shadows to be less prominent and the heart to appear enlarged. Now we have rotation. Rotation on a chest radiograph is assessed by judging the position of the medial ends of the clavicle and the thoracic spinous process. In a well-centered skiagram, as in the first image, the spinous process is equidistant from the medial ends of the clavicles bilaterally. However, in the second image, we can see that the medial ends of the left clavicle is closer to the spinous process than the right clavicle. This indicates rotation. Why is rotation important? Rotation of the patient distorts mediastinal anatomy and makes the assessment of cardiac chambers and the hilar structures especially difficult. Now we have magnification. So magnification on a chest X-ray is referring to the apparent enlargement of structures on a radiograph compared to their actual relative size in the body. X-ray tends to travel in straight line and diverge as they leave the source. And when the object is closer to the detector, as in a PA film, the image or the shadow that is projected onto the film is sharper and more accurate than when it is farther. So if the object is away from the film, the shadow cast is larger. This leads to a loss of sharpness and magnification. Magnification affects the final image by size distortion. Diagnostic impact is that it leads to false positives like misdiagnosing cardiomegaly. And also there's a loss of sharpness which leads to more blur and it reduces the edge detail of the radiograph. Finally, we have angulation. Angulation refers to the angle of the X-ray beam to the perpendicular orientation of the patient's body. Typically, we try to keep it parallel to the orientation, and any deviation from this results in angulation. So, an apical view, as you can see here, is an example of how we manipulate angulation to get a better view of the apices. So, if the X-ray beam is angled towards the head, the film is called an apical lordotic view. So, what angulation does is that it can distort the appearance of anatomical structures and can stimulate or mimic pathologies as well. So apical lordotic view here is an example on how the angle can be manipulated. So this is typically used to look at lung apices. So there are different chest radiograph views. We have the posterior anterior view or the PA view, which is the most commonly done. Then the anterior posterior view, the lateral view, the lateral decubitus view, the oblique view, and the apical lordotic view. Since the availability of cross-sectional imaging beyond the standard AP, PA, and sometimes a lateral view, the rest of the views are rarely done. Moving on to posterior anterior view, it is the most frequently used view for a chest radiograph. It allows for a good overall view of the anatomy and identification of the pathologies. Indications are that it's used for the evaluation of lung fields, the heart size, and the mediastinum, the screening or diagnostic imaging in cooperative and ambulatory patients. So the detector is placed against the anterior chest wall, chin up, with the shoulders rotated forwards and pressed downwards in contact with the detector to displace the scapula from the lung fields. Exposure is made on full inspiration and centering is over the T5 vertebra. AP view is primarily done when a PA film is not possible. This is not ideal for subtle findings and produces a lower quality image than a PA film. So indications are bedridden or critically ill patients such as ICU or emergency, in portable X-rays such as in trauma, in surgery or in post-op care, in rib fractures, in uncooperative patients, and in pediatric age groups. So positions back, the patient's back is against the detector with the upper edge over the lung apices, and centering is done 3 to 4 inches below the jugular notch. Now, what are the primary differences between a PA and an AP film? The scapulae of the lung are off the lungs in a PA film and are over the lungs in an AP film. The clavicles appear more obliquely placed in PA films and are more horizontally placed in an AP film. The heart is of a normal size in PA film and apparently enlarged in a PA film, and the ribs are more horizontally placed in an AP film. Now we move on to the lateral view. So lateral view is primarily used for anterior and posterior localization of the pathology and evaluating retrosternal and retrocardiac shadows. So indications are that it's used to assess the retrosternal and retrocardiac shadow, detect lower lobe consolidation, confirm presence of mediastinal mass, and evaluation of the thoracic vertebrae and the posterior costophrenic angles. So the patient is turned to the side and in contact with the cassette or the detector so that the mid-sagittal plane is parallel to the cassette. The arms are folded over the head or raised above the head. Conventionally, we take a left lateral view of the chest X-ray, but we prioritize the view we suspect the pathology. Now, I will discuss about lateral oblique and the other views, but these are more for historical context since the advent of cross-sectional imaging. So, lateral decubitus view was primarily used for assessing minimal pleural effusion and to demonstrate whether pleural effusion is mobile or loculated. This oblique view was used to be done mainly to look at rib fractures, chest wall, retrocardiac area. And this is the apical lordotic view, which we have already discussed. This was used to look at the lung apices in a patient in which we are suspecting apical pathology. Now I would like to call Dr. Arzoo to continue the presentation.
Good morning, everyone. A good understanding of a chest radiograph is the key to unlocking a more accurate diagnosis and improving patient care. So, I'll be speaking about anatomical details on chest radiograph and what we can and wish to depreciate while reporting a chest radiograph. So, first we'll see with the outside to inside approach. The outside to inside approach is a method used to interpret a chest radiograph systematically, ensuring that no critical details are overlooked. It involves looking from the outermost structures, that is, firstly we have to see the soft tissue, the white thing which you can see at the outermost, the soft tissue. Then we'll have a look at the bony cage, all the ribs, anterior and the posterior ribs, both clavicles, the visualized cervical and the thoracic vertebrae, and the visualized part of the bone forming the shoulder joint. Now, after the chest wall, we have to see the both dome of diaphragm, right diaphragm and the left diaphragm, and the angle formed by the chest wall and the diaphragm, which is known as the costophrenic angle, the angle formed by the diaphragm and the heart, cardiophrenic angle, and then we have to look the bilateral lung parenchyma. We have to see the discrepancy, if there is any discrepancy between the lung parenchyma, any radio opacity or any excessive radiolucency are seen in the bilateral lung parenchyma. Then we'll move to the midline structures. The radiolucent tubular structure in the midline, then trachea, is the trachea. Then we have to come down and look for the hilum and the mediastinum. We have to look for its shape, size, and the orientation of the hilum. The hilum, the major contributor of hilum are pulmonary artery, veins, lymph nodes, and the bronchial wall. And then we have to look for the abdomen. Now there's hidden areas. These hidden areas are difficult to visualize and interpret as they are usually overlapped. They are usually overlapped by the structures and are usually missed while reporting. So we have to see these hidden areas meticulously while reporting any chest radiograph. And these hidden areas constitute bilateral apices, hilar region, retrocardiac region, and the area below the diaphragm. Now I hope we kept a structured framework that what all we should see while reporting a chest radiograph. Now we'll see the basic anatomy. The pulmonary fissures are formed by the visceral pulmonary pleura and divide the lung into different lobes. In the right, we have one minor horizontal fissure and oblique fissure, and in the left, we have only one major oblique fissure, which divides the right lung into right upper lobe, the area between the horizontal fissure and the oblique fissure, right middle lobe, and the right lower lobe, the area behind the below the right oblique fissure. And in the left lung lobe, it divides it into the oblique fissure, divides it into the left upper lobe and lower lobe. Now this horizontal fissure runs from the hilum to the sixth intercostal space in the axillary line. And whereas these oblique fissures commence for viewing the fissures, basically we usually see these fissures in the lateral chest radiograph. So firstly we'll see that this oblique of fissures commence posteriorly from the T4 vertebrae, then it comes downward to the hilum, and it ends, the right oblique fissure ends just behind the anterior costophrenic angle, whereas the left oblique fissure is more steeper and ends 5 cm behind the anterior cardiophrenic angle. This is the anterior cardiophrenic angle, and this is the posterior cardiophrenic angle, which we can appreciate in the lateral chest radiograph as the minimal, in fact the 50 ml of pleural effusion can be detected if the posterior costophrenic angle is blunt. Now the lung zones. The Filson divided the chest radiograph into 3 zones. The first pink, we divide the lung zone by the anterior end of the rib. Upper zone is the lung above the anterior end of second rib. Middle zone is described the area between the anterior end of second to fourth rib, which is demarcated as in green color in this chest radiograph, and the area below the anterior end of fourth rib is defined as the lower lobe zone. Please note that while reporting, we use lung zones, not the lung lobes. Now we'll describe about the bronchopulmonary segments. As we know, there are 18 bronchopulmonary segments, 10 in the right lung and the 8 in the left lung. Now, these are the bronchopulmonary segments. As I've discussed that this is the right horizontal fissure, this is the right oblique fissure, and this is the left oblique fissure, which divides it into right upper lobe, right middle lobe, and right lower lobe, and left upper lobe and left lower lobe. Now, right upper lobe has apical segment, anterior segment, and posterior bronchopulmonary segment, whereas in left upper lobe we have anterior segment and apico-posterior segments. For further delineation, better delineation of bronchopulmonary segments, we usually see these in lateral chest radiograph. So this is the right horizontal fissure, this is the right oblique fissure, this is right upper lobe, right middle loop, right lower loop. Right middle loop has two segments, medial bronchopulmonary segment and lateral bronchopulmonary segment. Right lower lobe has apical segment, anterior and medial segment, and posterior and lateral segment. Whereas in the left lateral chest radiograph, we have lingular segment. There are two further classification of lingular segment, that is superior lingula and inferior lingula. And left lower lobe is divided into apical segment, anterior and medial segment, and
सब दिखते हैं क्या fissures या based on your anatomical knowledge you just mark them?
fissures.
Yes.
Fissures.
दिखते हैं?
Yes, sir.
दिखाइए.
So this is the schematic representation we have already drawn.
We don't see the fissures per se, but we take the anatomical landmarks.
Yeah, this is what I'm saying.
Yeah, but we can see it on CT very well.
We are discussing only about the axial chest. So based on our anatomical knowledge, we divide it.
Either what we used to do is surface landmarking.
That's fine.
So basically, this lateral view is what we are showing. If it's only a representative image, we can evaluate.
We can ascertain the possible location of a pathology if the lesion is like if anterior is written or apical is written. अगर वहाँ पर pathology तो हम सोच सकते हैं कि apical segment और upper lobe में होगा. हाँ वो clear
नहीं होता ना.
नहीं वो.
It is better that we कौन सा था Felsen criteria upper zone middle zone.
हाँ, yes,
हाँ.
Why that is better?
हाँ.
Rather than.
So we will be coming into that like lobes, which segment and which lobe they are located. There are few signs like one is if the lesion is limited by a horizontal fissure on the right side, then it becomes the lower lobe, the right upper lobe. So that is what the fissures are important. Like they can be displaced as well. So that is
Important message that is based on anatomical knowledge and not.
Shift in the collapse and also the constellation it makes the body. So it is always the very well
What clinical difference it will make? What clinical difference it will make? By seeing
the
the
difference definitely. No much clinical difference. The consultation better but at least the academically able to differentiate it. Into the upper lobe and upper lobe also we can able to differentiate it's the apical lobe posterior and tibial segment. That is what. Academically it is important. Of course, clinically it is.
if the lesion is in the right middle lobe, then we have to definitely look for something in the hila which is obstructing or which is narrowing that particular bronchus.
Differentiating between collapse and consolidation, there comes an importance of the fissures. Because in collapse the fissure is divided and in collapse it is anterior.
One is consolidation causes expansion of that particular lobe. So, and collapse will cause the accelerated shift of the fissure.
Yeah, collapse there is a shifting of the fissure from its normal location. So that is a very important point. Into the collapse and diagnosis of collapse is made the direct side, which is the collapse shifting, whether it is up, down, as per according to collapse. Collapse of particular. Yeah.
Should not get confused. You can see the fissures on the it's based on the anatomical.
Now we have to look for the radiolucent structure in the midline, which is trachea. The trachea is divided into the right main bronchus and the left main bronchus. The right main bronchus is smaller, steeper and more horizontal. So the chances of foreign body aspiration are more towards in the right bronchus. The angle formed by the right and the left bronchus is the carinal angle, and which is the normal angle is 60 to 75 degree. In the trachea, we have to see its deviation, its narrowing, and any intraluminal lesion is there or not. Now the hilum. The hilum constitutes of pulmonary artery, pulmonary veins, and lymph nodes. Now the mediastinum, it lies in the midline of chest between the pleura of each lung and extend anteriorly to posteriorly from sternum to vertebral column, and superior to inferior to superior thoracic aperture to diaphragm. Now we have two classification. Now firstly I discuss the Filson classification of the mediastinum to divide the mediastinum into anterior, middle and posterior. And for these classification we need lateral chest radiograph. So we'll draw two lines. First red line. Red line is drawn from the anterior border of the trachea to the posterior border of the heart. Now the second blue line, which is drawn 1 centimeter behind the anterior margin of the visualized thoracic vertebrae. So the region anterior to this red line is anterior mediastinum, and the region behind this blue line is the posterior mediastinum, whereas the region between them is the middle mediastinum. However, in the further clinicals, while reporting a chest radiograph, we use certain classification of the mediastinum, which is, firstly, we'll divide the mediastinum into superior and inferior mediastinum. We'll draw a line from the manubrium sterni to T4 vertebrae. Above this is the superior mediastinum, and below this line is the inferior mediastinum. Now, inferior mediastinum is drawn into, is divided into anterior, middle, and posterior mediastinum. For that, the blue line which I have showed you in the Filson classification remains the same, the posterior boundary. That we have to draw the one line, 1 centimeter behind the anterior margin of the vertebral body. This, however, the first anterior line which we are drawing is from the anterior border of the trachea to the anterior pericardium. So anything lies anterior to this line is the anterior mediastinum, and anything lies posterior to this, the line which we have drawn 1 centimeter behind the anterior vertebral margin is the posterior mediastinum, and the region between this is the middle mediastinum. So anterior mediastinum contains thymus, lymph nodes and the sandy aorta. The middle mediastinum contains heart, pericardium, great vessels, esophagus, and the posterior mediastinum contains vertebral bodies and paraspinal regions. Now heart border. Now we'll discuss about the heart border. So heart border is mainly formed by the right heart border is formed by the right atrium, whereas the superior vena cava here drains into the right atrium and the inferior vena cava here drains into the right atrium. The left heart border is formed by the aortic knuckle, followed by aortopulmonary window, left atrial appendages, and the left ventricle. Here the right ventricle, the base of the heart is formed by the right ventricle. Now we have to look for the diaphragm. This is the right hemidiaphragm, this is the left hemidiaphragm. We have to look for the contour of the bilateral diaphragm, that is contour is smooth or not. And as the difference between the right hemidiaphragm is slightly upwards, higher placed than the left hemidiaphragm, which is not because of the liver pushing the right hemidiaphragm superiorly, whereas it is because the heart is resting on the left hemidiaphragm, which is depressing the left hemidiaphragm. So normally right hemidiaphragm is slightly superiorly placed as compared to the left hemidiaphragm. Whereas if the difference between these two diaphragms is more than 3 cm, then we have to consider that some pathology is there. We have to look for the costophrenic angle. It should be clear, and the normal costophrenic angle is less than 30 degrees. Now the cardiothoracic ratio, we draw a line, midline, the blue line from the spinous process of the thoracic vertebrae, and with the normal centering which we usually done in the chest radiograph at the T4 vertebrae, the 2/3 of the cardiac cell house lies to left of the this midline, and less than 1/3 of the cardiac cell house lies to right of the midline. Now to evaluate the cardiothoracic ratio, firstly we will draw a line, blue line joining the spinous process of all the thoracic vertebrae, and then we have to see the maximum cardiac diameter. For that we have to add the 1 and the 2 mark structure. 1 is the maximum diameter from the midline to the outermost part of the right heart border, and the second is the maximum diameter from the midline to the outermost part of the left heart border. We'll add these values and we divide this by the thoracic diameter, the maximum thoracic diameter. If this is less than 50%, it is normal. Whereas if it is more than 50%, it is cardiomegaly. These are the dimensions for a PHS radiograph. If it had been a AP film or an infant, then we take the cutoff as the 60%. Now we have to see the bony thorax very clearly. We have to see all the anterior and the posterior ribs. We have to see the.
कैसे पता लगेगा कि anterior side है, rib का posterior side है? How will you know?
Sir, these are the ribs which we can see. These are the posterior ribs, and the ribs which are coming from the behind. These are the anterior ribs. As this.
I do not mention, like in this axis is not mentioned whether it is a PA view or AP view.
Yes, sir.
How will you say?
Sir, we have to see the many features that in the AP view, basically these ribs and the clavicles are the more horizontally placed. The scapula are the out of the field, scapula in the field of the view of the lungs, and we can see the magnification of the heart in the AP film. Whereas in the PA film, we can see that these are the clavicles and the ribs are the obliquely placed. The scapula is the outside of the lung field, and the heart is not heart is normal in size. It is not apparently magnified.
आपने जो लिखा है ना posterior ribs on the right side,
Yes, sir.
anterior ribs on the left side, you are showing marking, no? So explain with that.
वर्टिब्रा से वर्टिब्रा है ना, जहाँ पे वर्टिब्रा वाली अटैचमेंट है वो पोस्टीरियर एंड हो गई। सर बोल रहे हैं उसको ड्रॉ करो जैसे फर्स्ट स्टेप को जैसे।
Achha, okay, sir. So this is the first anterior rib. This is the second anterior rib.
एंटीरियर नहीं, सेकंड रिब का फर्स्ट रिब का पोस्टीरियर एंड और एंटीरियर एंड।
तो एक ही है।
हाँ, yes, anterior end और posterior end है, yes, sir.
कौन सा एंड कंप्लीट होता है?
Posterior.
posterior
Yes.
spine तक जाएगा।
Yes, sir. This is the
इंटीरियर में
posterior.
कार्टिलेज होगा।
हाँ जी, sir. This is the posterior end of rib, and these are the anterior ends of the rib. So we have to see these ribs, and we have to see the contour of this ribs. Any fracture is there, any deformity of there in the bony structures in the clavicles, or the visualized bone forming the shoulder joint. And then we have to see any destructive, any osteoblastic or osteoclastic reactions if they are seen in the bony thorax. Now we have to look for the soft tissue. The soft tissue involves the soft tissue of the along the lateral chest wall, axillary region, and in the visualized neck region. Then we have to also look for the breast shadow and the nipple shadows. Now, what all we should appreciate on a chest radiograph? So this is the checklist. Whenever chest radiograph come to us, we have to follow this for the proper reporting of a chest radiograph. Firstly, we'll get the request form. We'll see the indications and the confirm the identity of the patient. Then we'll see the technical aspects if they are normal or not. Then in trachea, we have to see its position and outline. In the heart and mediastinum, we have to see its size, shape, and displacement. In the diaphragm, we have to see its outline, shape.
Especially for the clinical residents,
especially for the residents, whenever you see an X-ray film, first of all, make sure to confirm patient identity and the date of the X-ray. Many patients will come to you with 3 or 4 radiographs. First of all, you see कि वो उसी पेशेंट के हैं और वो डेट देखो और उसके बाद में सीरियल रेडियोग्राफ्स का आपको मिले. This is very important.
Now, in diaphragm, we have to see its outline, shape, and the relative position of the both diaphragm. In pleura, we have to see the position of horizontal fissures, costophrenic and cardiophrenic angle. In lung field, we have to see any focal or diffuse abnormality, comparison of translucency and vascular marking of the lungs. Then we have to see the hidden areas very meticulously, the apices, retrocardiac area, palatal-hilar region, and the region below the diaphragm. And in hilar, we have to see its density, position, and shape. Below diaphragm, we have to see the gas shadow. The normal below the left diaphragm, we can appreciate the gastric bubble. But we have, if the free air is there, then we have to get.
Can be gastric, it can be colon.
Colon, yes. Colon also. Then in soft tissue, we have to see if there is any mastectomy or not. So breast shadow is important. Any gas shadow is there, or any other density, metallic, or any other densities are there in the soft tissue. In bones, we have to see fractures or any other destructive lesions. So now I would request Dr. Sarthak to please come and have a words on artifacts and importance of serial radiographs.
Thank you, Dr. Arzoo. So I will be speaking on artifacts and the importance of serial radiographs in this upcoming segment. So artifacts, these are just misleading shadows or patterns on a chest radiograph that do not represent true anatomical findings or a pathology. These can be due to patient factors like motion, clothing, hair, jewelry. They can be due to technical factors like cassette or detector handling issues, scratches on the cassette or the detector, fingerprints and general flaws in the imaging devices. And there can also be processing errors such as ghosting. So ghosting is when a detector or a cassette is not cleared of the last image and there is superimposition of the new image on top of that, if there is not proper handling. So they are important to know because they can obscure and mimic pathology as well. So for example, in this radiograph, we can see a hazy opacity in the right upper lung zone, which is suggestive of consolidation. However, we can follow this opacity up and out of the lung field as well. So this actually so upper है because ये first rib आ रही है, ये second rib आ रही है, ये आ रही है second rib. Primarily in the upper lung.
Any medicine resident who can point out this is this artifact. It is artifact for sure. अंदर से बाहर जा रहा है patient.
Yes, sir. So this turned out to be the hair braids of the patient, and the patient was not adequately positioned. So here we have a patient hair artifact mimicking a consolidation. So in this we can see clothing artifacts by the way of hooks that are present in this image. And this is another example of a clothing artifact in a child. We can see that the words on his t-shirt got imprinted onto the face as a passage. Yes. Literally, it spells Star Wars. Now we move to serial radiographs. Now, these are taken over time. These are chest X-rays that are taken over time to monitor progression or resolution of thoracic conditions. These are commonly used to track diseases such as pneumonia, pulmonary tuberculosis, pleural effusion, pneumothorax, and post-operative follow-ups. The main advantages of doing serial chest radiographs are that they are widely available, they are cost-effective, and they have use in monitoring changes over time. Now we'll discuss two examples of this. So in this case, there was a young male who was undergoing an elective surgery. This was the preoperative radiograph. This was after endotracheal intubation. This chest X-ray was taken after endotracheal intubation, and we can see haziness in the right perihilar region, which a diagnosis of aspiration pneumonia was eventually made for this patient. And this radiograph was after complete treatment was given and the patient was discharged, in which we can see that both lung fields are normalized. This is another example of serial radiographs. This patient, in the first X-ray revealed right pleural effusion, which turned out to be tubercular in etiology. After these two were taken after 1 month and 2 months respectively of ATT. This was taken after the 3rd month, in which we can see that the right postophrenic angle is minimally dull, which indicates that and we can also see throughout the radiographs, there is progressive decrease in the amount of pleural effusion on the right side. Now I would like to invite Dr. Jain to conclude this one.
So the take-home message for today's presentation is, whenever we see a chest radiograph, very important, just assess the quality of the chest radiograph. The commonest problem you people will encounter in a chest radiograph is that many of the X-rays are rotated. So you should be able to recognize a rotated or not centered chest radiograph. I know an incident where a CT scan of chest was done only because the chest PA radiograph was rotated and the doctor thought that there is hilar lymphadenopathy on the right side, and the CT chest was turned out as normal. Then knowledge of normal anatomy is very important to recognize abnormal, and then obviously we should be aware of the various artifacts which we can see on a chest radiograph.